Good afternoon. My name is Hyojin Kang. I am the program manager for TAVR program here at Mount Sinai. I will be talking about TAVR as treatment for aortic stenosis and cerebral protection device. I have no relevant financial relationships. So prevalence of valvular heart disease increases with aging, and aortic valve disease is the second most common valvular disease, followed by mitral valve disease. And as you can see in this graph, it starts peaking in late 60s to 70s and on. Treatment for valve disease is evolving because of increasing patient age. Our patients are older, they live longer. Increasing patient complexity, these patients are sicker and they don't just have high blood pressure, high cholesterol, and diabetes, but they have extensive history of medical complex with comorbidities, which is not so easy to treat. But the good news is that there has been advanced medical therapy, which has led to better patient outcome. And there has been improved surgical expertise, again, which led to better outcomes. And emerging medical invasive alternatives such as TAVR, which has changed the treatment choice for aortic stenosis. So before we dive into in depth about aortic stenosis and TAVR, I wanted to show you the picture of what severe aortic stenosis look like. So as you can see, that is the echocardiogram of what severe AS looks like, and that is the picture of the thickened leaflets because of the calcium deposits. And because of these thickened leaflets, the valve does not open and close easily. What is aortic stenosis? Simply, it is the narrowing of the aortic valve. It is more common with advanced aging. Again, this aortic stenosis affects our elderly populations. We start treating our patients with aortic stenosis with TAVR in their ages as young as in their late 60s to as old as in their hundreds. So I'm gonna share this story with you guys that in just past January, we actually did a TAVR on a 104-year-old patient as a live webcast. We all were a little hesitant, but our Dr. Sharma insisted that we do this case as a live webcast. So this patient did so well that the very next day, this patient was discharged home. The very next day, and then that weekend, this patient turned 105. A couple months ago, we received a very nice picture from the family of her celebrating at her great-granddaughter's wedding. So there is no age cutoff in TAVR. So aortic stenosis is wear and tear of the aortic valve where the calcium builds up. It reduces blood flow exiting the heart, then which our heart has to work extra harder to pump this blood out, and which then leads to our heart to decompensate. So the classic signs and symptoms of aortic stenosis to look out for are the shortness of breath, fatigue, decrease in exercise tolerance, leg edema, dizziness, and syncope. Although you might have be diagnosed with aortic stenosis, we don't treat right away. So when is aortic stenosis severe? Severity is determined by echocardiogram, and it is classified as severe aortic stenosis when the valve area is less than 1.0, and mean gradient greater than 40, and peak velocity greater than 40. So aortic stenosis is life-threatening, and it progresses rapidly. Survival after onset of symptoms is 50% at 2 years and at 20% at 5 years. So when we educate our patients, we always tell them that this is progressively worsening disease. It does not get better, it only gets worse. So our patients who are diagnosed with aortic stenosis, it doesn't have to have any symptoms, and they're asymptomatic for years, but once they start experiencing these symptoms, then there is a rapid decline in survival. Fact about severe aortic stenosis. In the United States, there's about 50% of patients with severe AS will not be referred for treatment. So what are the reasons for lack of treatment for severe aortic stenosis? That primary care doctors are not aware of this TAVR procedure. Still, there are many PCPs who are not up to date with the latest treatment options and the indication for this treatment. Often our patients are told that you're too old or too sick to have surgery. Again, this is our elderly population who are hesitant to go for any kind of invasive procedures or surgery. Also, they're told you're getting tired because of your old age, or you can't move fast because of your arthritis. But in all fact, they're extremely tired and they don't want to move around too much because their heart is working so hard that their body is just exhausted. So treatment options for severe aortic stenosis. Medical therapy does not work. It is a mechanical problem, so only definitive treatment is by replacement. It can be done by surgical aortic valve replacement, TAVR, or it can be done by transcatheter aortic valve replacement, TAVR. So initially, TAVR was indicated for those who are deemed as inoperable or too sick to have surgery. But in 2012, FDA approved TAVR for high-risk patients, and in 2016, it was approved for intermediate risk. And in 2019, August of 2019, low-risk patients were approved. So now TAVR is indicated in all surgical risk patients. Having said that, now the TAVR volume has exceeded SAVR volume. Surgery has been around since 1960s, and it has been the only treatment option for aortic stenosis. But since the TAVR has come along since the last 10 years, it's already taken over. With increase in TAVR volume, now there are about 750 TAVR centers in the United States. As you can see, our area is overly saturated with TAVR centers. So what what Beth has mentioned is that what American College of Cardiology launched this transcatheter valve certification in 2019. And what ACC transcatheter valve certification focuses are that they focus on the best practices for implementing evidence-based medicine to support shared decision-making in the care of individual patients. It tracks key performance metrics to better identify opportunities for improvements, and there are only 6% out of the 750 TAVR centers are certified, and like how Beth mentioned, Mount Sinai TAVR program was the first and still only up to date that are certified in New York City to receive this ACC certification. So why is TAVR preferred over SAVR? It's less invasive, right? You don't have surgical incision. There you don't have to be on long bypass machine. Shorter hospital stay, right? Our patients are discharged within 24 to 48 hours. Faster recovery. Our patients are back to full activity level within 1 week. And data speak for themselves. So there was no difference versus SAVR at 5 years in high-risk patients, and there is no difference or better data versus SAVR in intermediate-risk patients, and there is no difference versus SAVR in low-risk patients. So if all the data shows that there is no difference between SAVR versus TAVR, who would want to have open heart surgery? Just a little comparison between surgical AVR to TAVR is that surgery, obviously, OR time is about 4 to 5 hours. These patients are intubated. They are put on perfusion bypass machine, and they do have surgical incision, and average length of stay is about 5 to 8 days, and they do need to go to ICU right after their surgery, and they might have chest tube along with other invasive lines like Foley and central line. And average recovery to full activity is about 3 months, and often their pain is managed with narcotics. Whereas in TAVR, the catheter hybrid time is about 2 to 3 hours. Most of our patients are done under MAC. Rarely, I would say not even 5% of our patients are done under GA, and even if they're under GA and they're intubated, they get extubated at the end of the procedure. We do have perfusion on standby, but we rarely use them. And access is about 95% transfemoral, and average length of stay is 1 to 2 days. And invasive lines such as IJ or arterial line are removed at the end of the procedure. And they are able to fast track bypassing ICU. They go to step down or cardiac care unit right away. And average recovery time to full activity, again, is about 1 to 2 weeks. And narcotics are not necessary. Usually they do complain of a little soreness in their groin, but it is managed with over-the-counter pain medication. So as TAVR has advanced over the 10 years, complications such as pacemaker, bleeding, vascular complications, mortality have all come down, but the stroke rate has not. So the rate of 30-day stroke following TAVR has not changed over the time since TAVR has started. And we found out that majority of stroke within 30 days of TAVR procedure occur within the first 3 days. So 48.9% of stroke occurred within the first day following TAVR, and 68.4% of strokes occurred within 3 days following TAVR. So sources of debris during TAVR, this debris can be found in ascending arch, transverse arch, and also stenotic valve. I don't know if you could see in this picture, but there's this white dots of this calcium debris that can be floating around at any given time. Also, foreign material like TAVR devices, like delivery system, can shift this debris around at any time when they're working. So Sentinel, which is the cerebral protection system, is the only FDA-approved cerebral protection system on the market. And it has 2 independent filters which captures and removes the embolic material. It's made out of polyurethane filter, and the standard right transradial sheath size, which is 6 French, and one size accommodates most vessel sizes. So deflectable compound curved catheter facilitates cannulation of left common carotid artery. And minimal profile in aortic arch, which translates that there is little interaction with other devices during the procedure. Sentinel filters more than 90% of blood flow to brain. As you can see in this picture, both right and the left common carotid artery, along with the right vertebral artery, is protected, and only left vertebral artery is not protected. So these are the debris captured and removed by Sentinel. And I have to point out that once the procedure is over, the Sentinel is removed. So think about this debris still floating around, and now it's not protected. So when to use Sentinel, it should be attempted in all possible cases, but unsuitable when there is no right radial artery access, or there is need for right radial A-line by anesthesia because the patient might have left AV fistula, or if they have tortuous inanimate or any kind of subclavian anatomy which prevents from Sentinel going in, then we can't be attempted. And if there's any need for right radial artery access for any other purposes, then we don't try to attempt to use the Sentinel. So TAVR stroke in hospital, 30 days and over a 1-year stroke, as you can see in this data, from the time TAVR has been around, has been remaining stable. And as you can see, 2018 is the year when cerebral protection was approved by the FDA. Although it's not a rapid decline, there is a slow decline in stroke. So take-home message is that stroke in TAVR remains 1.5 to 3% across studies and is stable over time. And most strokes occur on post-op day 1 to 3. And risk factors for stroke are multifactorial, including prior stroke and AFib. And cerebral embolic protection may help reduce debris during procedure, but does not protect after the TAVR. And thank you, that is it. Sure.
Do you have a dedicated TAVR team? You want to talk about that?
Yes, we do have a dedicated team. Our team consists of 4 full-time nurse practitioners. We have 1 dedicated nurse practitioner who goes to see our outpatient clinics. And we have one inpatient dedicated nurse practitioner who rounds on our inpatients, post-op patients, or who are getting the workup done as an inpatient. And obviously me, who oversees every operation in the office. And we have another nurse practitioners who just fill in the gap wherever the need is. Yes, we have a it's called a True Heart Team discussion where we meet every Monday. It is led by Dr. Sharma and our surgical director, Dr. Tang, our echocardiographer, Dr. Larakis, along with other interventional cardiologists. We meet about for 1 hour where we go through every single patient. We bring up the test results that are questionable, that are worrisome. We bring up social issues that our patients might have. So then if we need to be, then we get social workers involved just so that we have so that we are prepared when these patients are coming to us for the TAVR procedure itself, that everybody is aware of wherever the help is needed.
Excellent. And I think that you answered this, but just, it says, do most of your TAVR go under general or moderate sedation?
It's monitored anesthesia care, which means that they are asleep, they're kept very comfortable, but they're not under general anesthesia or they're not intubated. I would say about 95% are done under monitored anesthesia care.